Welcome to the Dose of Optimism, where I talk to the optimists in healthcare. My name is Omkar Kulkarni, and I work at one of the world's best children's hospitals where I lead innovation. I started KidsX, which is a premier international startup accelerator for pediatric innovation. And over the years, I've met thousands of startups, investors, and innovators. Every one of them has a story, and every one of them is optimistic about the problems they're solving. On this podcast, you'll meet amazing people who will share their stories and what makes them optimistic about the future of healthcare. A little note before we get into this episode. This podcast is for informational purposes only. We are not offering medical advice, and we're not endorsing any products. Please talk to your own physician about your health or the health of your children. All right, let's get started. Today's first guest is Dr. Larry Deeb from Tallahassee, Florida, a true champion for kids living with diabetes. Larry is a pediatric endocrinologist who spent decades improving care for children and families. He's a past president of the American Diabetes Association. He's deeply involved with ISPAD, the International Society of Pediatric and Adolescent Diabetes, and he's passionate about global health through the Life for a Child program, making sure no child dies for a lack of insulin. He's also very active in Rotary International, leading efforts to fight diabetes worldwide. He's helped educate pediatricians in India, Africa, China, and many other places around the world about innovations in diabetes care for kids. What's really impressive is that Larry has brought innovative diabetes care to Tallahassee and the surrounding North Florida region, a place that traditionally may not be the first to receive cutting-edge treatments. His career spans over 50 years, starting in the early days at the CDC, and he's never stopped pushing boundaries to make life better for children with diabetes, everywhere. Most important to me, he's my father-in-law, and I'm lucky that he sat down for this interview to walk through the 5 decades of innovation and research he has contributed to pediatric diabetes care. I hope you'll enjoy this conversation with Dr. Larry Deeb.
Life is all about people. But a story I'd like to tell you is when I went back on active duty after my fellowship, I had the opportunity to take a bunch of kids hiking in Wyoming. And this is 1978 or 79. How do you reckon we managed their diabetes? Well, I'll tell you. We were hiking. I would send them off into the bushes. They would urinate, or if you're a pediatrician, pee, on a strip. Bring it back and let me look at it, and I'd figure out how much insulin they needed.
Oh, wow.
The whole idea of my entire career is how can you make it so people live with diabetes? And adolescents hike in mountains.
That's right. Kids like to be out there and doing their normal things in life. From the 70s and 80s through now, the management, the treatment, perhaps even the diagnosis of diabetes, help the audience understand how we've evolved over time in the last 50 years.
So I suppose 2 of the major leaps forward were the ability to measure blood glucose at home. And several companies introduced those in the early 80s, which was just, an absolute breakthrough.
Right.
Before then, you were measuring urine at home, how much glucose was in it. You don't spill sugar in your urine till your blood sugar gets reasonably high, which means you're already, as it were, late when you see the blood sugar in the urine. Blood sugar is 170, 180, which is already high.
But that's how it was measured before the 80s, you're saying?
Yeah. So we're always late and therefore really not managing diabetes. And then the introduction of the concept of hemoglobin A1C. Sugar sticks to red cells in a real chemical reaction, and red cells last about 100 days. So you're able then to measure how much sugar was stuck to it because it changes the hemoglobin and makes it different enough you can measure.
That biomarker was introduced at some point in, was it the 80s?
In the early 80s, yes.
Wow, okay.
So had both of those things come together. And I'll tell you another story. So I'm sitting with the chief medical officer of Blue Cross of Florida and talking about measuring blood sugar in patients. And he looked at me like I'd lost my mind. Why would anybody want to prick their finger, let alone 3 or 4 times a day? And I don't know if I ever totally convinced him, but they ultimately began to pay for it. That's all. I mean, really, think about that. Why would anybody want to? Nobody really knew if managing diabetes made any difference. Why do you want to put them through all this because they're going to die young anyway?
Oh, wow. So it was at that moment, it was not something that you lived with chronically for your whole life. It was something that would kill you.
Yes. And if you look at life expectancy, people diagnosed in various decades, that really was true. And in 1983, the landmark diabetes control and complications trial, they were able, because we now had A1C, to separate it into two groups. And they really had typical control, 9 A1C, 180 blood sugar average, versus 7 A1C, 160 blood sugar average, 150. I mean, really dramatically better.
Yeah, they could really see those changes. What we take today is a life-changing disease, but one that has a management curve to it from a parental and a child standpoint. When you started, it was not the case.
So now we got to do something. We had some toys. We could measure A1C. Pumps were coming, but they were still relatively archaic and they evolved probably next. Continuous monitoring is a 21st century thing, but the pumps were 1990s. And with that, you could a bit more closely mimic the normal day with diabetes. And interestingly, too, during the 1990s, we had the advent of better insulins. It all came from pigs and cows. So we had pure human insulin. In the 90s, we modified the insulin, and the original insulin lispro or Humalog trial, which I had the privilege of being the initial principal investigator, really showed improvements in overall management by using faster acting insulin. The introduction of longer acting insulin in the 1990s. So we had better measurements, better monitoring, and better insulin evolved during that decade, which made managing better.
And the pumps then created a world where the kids could have their insulin and their sugars managed better over time, too, right?
Right. No matter what you do when you give insulin, if, for example, I give you an insulin that lasts 24 hours and you don't have a meal, but the insulin is working, you could get into trouble. Your blood sugar could get too low. The ability to have any sort of flexibility in your life was dramatically reduced for a long time when you had diabetes.
What was the reaction with patients as it was something really novel, whether it was the pump or whether it was pricking your finger or eventually the CGM? These are very different new technologies or new ways of doing things. What was the patient reaction on the first year of some of these introductions?
Well, most of the time, you always have early adopters jump on anything that's new. And in the retrospectoscope, when someone finally goes, yeah, I think I'll try that. One of the privileges I've had is a healthcare system that supported everything new. I've had endowed educators and dietitians and social workers for decades. And they would go to conferences and we would come home ready to teach as opposed to being a decade behind. I was really blessed with that. I can't say that strongly enough.
Yeah.
With the healthcare system here, we created it to really manage children's diabetes.
Along the way, I assume you've seen a growth in type 2 diabetes. What was that like? What were those early reactions amongst your peers when you saw the rise of type 2?
I can remember going to a meeting in Moscow in 1988, supported by the WHO. And I wrote a paper on the rise in obesity in children and the effects on blood glucose.
Wow.
And into the 90s, that came true. Today, Omkar, today, 1 in 3 children is at risk with prediabetes.
Wow.
The obesity epidemic, we're up to, when you measure body mass index or some measurement of obesity, in the 1970s and 60s, 5% of the kids were in the top 5%. Today, it's over 20.
Wow.
So they're over 95% BMI, plus 2 and 3 standard deviations, any way you want to look at it. And that creates risk for all of the things related to obesity down the road.
Lately, there's been a lot of conversation about ultra processed foods, diet. There's a lot of factors that obviously impact obesity and prediabetes. But what's your thought around the impact of diet and health and how much that contributes to what you see in terms of going from 5% to 20% of kids at risk?
There was a recent output from CDC that said that adults in the population have 50% of what you eat is ultra processed, and children up to 70% ultra processed. So, yes, that's just a real issue. And you have to use the word ultra processed because you have to be careful. Touching something, maybe processing it, but
Sure.
it hasn't made it better living through chemistry, as it were.
So is the thought then that over time, I guess that would say before the 80s, that percent, if it's 70% now, kids ate less ultra processed foods in the 60s and 70s. And at some point, that number started going upwards, which is then contributing to that same kind of rise in prevalence of obesity.
If you even look at your childhood, what was available to be in the refrigerator was
Yeah.
dramatically different than the potential for what's available at your house now. One of the easiest things to remind people is that virtually every supermarket in America is laid out this way. If you shop the outside of the store, you mostly avoid the ultra processed food.
I want to talk about some of the work you're doing now. So, this era of screening or even diabetes prevention amongst children may be in our future. And you're doing a lot of interesting work in that space.
It's 2025 and your child is diagnosed with diabetes. Classic T1D, antibodies, 30% still go to the ICU. So they could have been really sick. And again, I remind parents that you see what you know. If you've never seen anybody with diabetes, don't know anything about it, the fact they've been getting up 3 times a night to go to the bathroom didn't particularly bother you. Remember, your sugar gets high, spills in the urine until you're not going to let that happen again for another kid. But they present with diabetes.
You told me though that's a sign though to go talk to your doctor, right? Is their kids
Mhm.
getting up in the night multiple times a night to go pee?
Yeah. Now they've got diabetes. And what are you going to do with them? In 2025, you should not go home from the hospital without a continuous monitor, period. Automated insulin delivery pumps now are available, and there's several different brands. They all give you insulin when you eat and watch your insulin go up. So if you need a little bit more, they can do it and watch your insulin when it comes down. And again, because we're using these rapid acting insulins, you can turn it off and wait till it starts back up and turn it back on. So I never would have had 10 years ago a 2-year-old child where 70% of their blood sugars were considered in target range. Never.
Wow,
And I do now.
that's
So
amazing.
I want people to hear that the 21st century demands that you be very proactive because then you can look at somebody with T1D, not a 2-year-old, they don't get it, but a 10-year-old or 11-year-old gets it. When you ask the question, how long do you plan to live?
Yeah,
Your 10-year-old daughter, if asked that question, would get buggedy eyed, right?
that's right.
I mean, you see the whites of their eyes and to be able to say, well, try 90.
Yeah,
Right.
just thinking about the very start of our conversation, and to your point, using the continuous glucose monitor, you can live that life, and there's so many adults living with it. Fascinating.
And living with diabetes as opposed to living for it.
That's true.
If you prick your finger at breakfast and print your finger at lunch and didn't know anything in between, wouldn't you worry about what it is right now?
It's so interesting to see that data because you learn how food and activity and everything else impacts your glucose, and you got to teach people how to use it. But the amount of information that's then available for the patient, the parents, your team.
Yeah, last year in Lisbon at the International Society for Pediatric and Adolescent Disease, one of the speakers who is a leader in the forefront of this said that he thought his greatest contribution to diabetes was mothers sleeping at night.
It's a really good way of thinking about it and makes sense. Peace of mind.
The peace of mind that I
Yeah.
know it is, I know it's going to be okay, and I can sleep. And if it's not, it'll alert me.
Let's finish with screening and prevention.
With the FDA approval in November 2022 of a drug that can be infused that looks as though it helps put off diabetes. And we're looking in other areas for different research studies to put off diabetes and or give medicines to help preserve the pancreas when you already have new diabetes.
So there will be drugs at some point in the future where patients that perhaps are higher risk for diabetes, it could either entirely prevent it or it could help with the prevention of diabetes.
As a person trained in epidemiology, I'm very involved in children with diabetes around the world and treating them through the International Diabetes Federation and the program Life for a Child. And we began that because it's a defined population you could deal with. You couldn't give everybody on earth insulin who needed it. For T1D, one child in 400 gets it, but you cannot screen every child in Los Angeles County.
You've got to pick a population that's more likely to be at risk.
So it's 1 in 400 if you're walking around in the street, 1 in 15 if your brother or sister has diabetes or your parent had diabetes. So dramatically different risks. The big push now in the United States for all of the organizations is T1D in the family, first degree relatives, brothers, sisters, children should be screened. And stage 1 diabetes is presence of one antibody. You have diabetes, but you now moved into a bigger risk group. You need to be looked at more often. Stage 2, more than one. Now we're for real. The risk is real. Again, not everybody gets it, but you need to be watched and maybe even have more sophisticated testing, glucose tolerance test. How well is your pancreas working? Hemoglobin A1C. Because that's the point where you don't want to get to stage 3, which is full-blown diabetes. We're at the point where we found families. The first intervention was a 2-week daily infusion. Now there are emerging studies and trials of using pills. The latest sort of interventions are looking at FDA-approved drugs used for preventing diabetes.
You've got a parent with type 1 or a sibling diagnosed with type 1. You screen the patient. If there's presence of antibodies, whether it's one antibody or multiple antibodies, you could theoretically take pills in the future that could prevent getting to stage 3 where you have full-blown diabetes. Is that right?
And none of this is long enough to say absolutely, but all of this is enough to say, wow, it's worth knowing and it's worth doing something about it.
There's a world where we could bend the curve of type 1 diabetes in the future because you're able to get to this level of prophylactic prevention through medication or whatnot and screening. But there's a pathway here towards not only management, which is what you've done over the last 50 years and optimizing that, but perhaps even to the place where we can detect, at least for type 1, those that are at highest risk. That's so interesting.
I mean, it really is. Who knows where the public health aspect of this goes with population that's not at high risk.
So what makes you most optimistic about diabetes care and detection for the future for kids?
The mother who, when I asked the question about 90, said, Dr. Deeb, you're going to make me cry. And I said, why? She said, tears of joy.
Yeah. A kid who's diagnosed, having the opportunity perhaps to live to 90. Whereas when you started, I imagine that would not have been something that even you would have thrown out there.
And when I say that, the children I took to the wilderness were all at late adolescence,
The Wyoming kids.
the late 70s. So they were born 1961, 62. So that would make them 65 today. I wonder if any of them are alive. It's emotionally amazing.
It is.
Imagine for a doctor. It can bring tears to me.
Yeah. Larry, thank you again so much for spending the time and walking through so many different things. I've learned a ton, and I think our audience will have as well. Thank you again.
Thank you.
And now a thank you to our generous sponsors.
All right, we want to thank our sponsors for A Dose of Optimism. Our first sponsor is Nabla. Nabla. This will help keep us practicing longer. For 85,000 clinicians and counting, Nabla is the key to better balance. With real-time notes and dictation in one platform, clinicians are saving hours on documentation time and strengthening patient satisfaction. Learn more on nabla.com. And to Mercury Bank, online business banking for startups and small businesses. Go to Mercury Bank for powerful banking, simplified finances. And finally, we want to thank our presenting sponsor, KidsX. KidsX is a global ecosystem of pediatric innovators anchored by a consortium of the leading children's hospitals motivated to accelerate health innovation and transform care in pediatrics. Let's head up Route 95 now to the city of brotherly love to talk to Dr. Senbagam Virudachalam from Children's Hospital of Philadelphia. Sen is a pediatrician and health policy researcher who's passionate about making sure every child has access to healthy food and a strong start in life. She's an assistant professor at the University of Pennsylvania and a faculty member at Policy Lab, where she leads work on food equity and family health. Her research focuses on helping families cook nutritious meals and creating community-based solutions to fight childhood obesity. She's also the director of food equity for CHOP's CARE Network, serving over 250,000 kids. With awards like the Bright Futures Young Investigator Award and partnerships with programs like Early Head Start, Sen is shaping policy and practice to help kids thrive. Dr. Virudachalam, thank you so much for joining us today.
Thank you. I'm delighted to be here.
You've been doing a lot of interesting work for over a decade. Would love to hear how it all got started.
Yes. So my parents immigrated here from southern India before I was born, and my grandparents on both sides of my family were small family farmers. My parents grew up on farms in an agricultural community. And I was fortunate enough when my parents could periodically save enough money every several years, we would go to India to visit my family. And I got to really experience and be in a community where food was at the heart of everything in terms of producing food, but also the community and family aspect, making meals and eating together. And then here in the United States, I grew up mostly in the suburbs of Chicago as most of my childhood. And for anyone from Chicago, you know that Chicago is a city of neighborhoods and people really hang on to their cultural and food traditions for generations. I grew up in this milieu where at home, food was a really important part of our culture and our family. And then in the community that I grew up, that was also the case. And so for me, I thought that was just how things were for everyone. And then I went to medical school on the East Coast and came back to the Bay Area for residency. And that was really my first experience being with families in the United States who were experiencing poverty. And I was really floored to realize that many of my patients, if I'm seeing them for an afternoon clinic visit, might not have really had anything to eat that day. Or if they had, it was often processed foods like oodles of noodles, Pop-Tarts, hot Cheetos. Those were some of the common answers that kids would give me when I asked what they had to eat that day or what they really liked to eat. And so that was a moment for me in residency where I realized that even though food and nutrition are at the bedrock of health and at the bedrock of child health and development, that there really was only so much I was going to be able to do in the context of the clinic in terms of supporting families with what they really wanted to do. Every parent I've ever met wants to nourish their child. That's sort of a universal human instinct and desire, but it's a complicated endeavor, especially with the way that our lives are structured in 2025 in industrialized countries like the United States. And so I wanted to kind of think about how to address that problem at a systems level. And of course, I am a pediatrician through and through, so I wanted to think about systems level change and contribute data and solutions to try to bring about change. We're all people, and when we meet in that exam room, it's a really beautiful moment where we get to be our most genuine selves together. And food is something we're all the experts in our own eating, right? Eating and hunger, it's just a fundamental part of being human. And it has been since the beginning through centuries of time and evolution. And so the work that I do, the research I do, the goal of my work is to ensure that all children have stable access to fresh foods in their homes and communities so they can thrive and grow into healthy adults. Specifically, I have worked over the past 15 years to develop a program called Home Plate that is a 6-week long food skills program for families and specifically focusing on families with very young children, though this work is easily adapted to older children and adults. And the reason we focused on early childhood is because that is the time when taste preferences are cemented. So we actually cement our preferences for certain foods and flavors in the first 1,000 days of life. So that's including in utero, and then just those first couple years after you're born. And really anything that happens after that is trying to change an existing behavior. It's a lot easier to lay a strong foundation from the beginning. And so we developed Home Plate in close partnership with Early Head Start at CHOP and many other community partners. And really it was developed by parents for parents. And the goal is not to turn anyone into a gourmet chef. This is a program where parents get together and cook together once a week for 6 weeks. It's really about getting people to, we all have been there at the end of the day, right? Where you get home from all the busy things out in the world, school, work, and it's hard sometimes to have the activation energy to put those ingredients together and put a meal on the table. And so that's really what Home Plate is about. It's about taking existing motivation. As I mentioned, all parents really want to feed their kids and themselves nourishing food. And so it's taking that motivation and building on the skills that people already have, and then getting over that activation energy and really building people's skills and confidence to be able to do that on a regular basis. This is an experiential learning model, and the objectives for each week are loose objectives. The discussion is meant to be tailored to what individual parents in each group really want to talk about, and to be able to prepare foods that they and their children will enjoy and eat those foods. And of course, the meals are healthy, but the focus is actually more so on the process and enjoying the cooking, enjoying the eating. And it's not a program that is all about didactics, because most people, I think, have a pretty good sense of what they quote unquote should be doing. It's about putting it into action. That's the hard part.
Are the kids involved in cooking? Are they involved in kind of picking what to eat? What's the child's involvement? I've got kids and they love looking through cookbooks. Whenever they're like, I want to try this recipe, even if it's something that looks hard or something they never tried before, my wife and I try our best to go and cook it because they've shown the slight enthusiasm of trying something new. And so we want to at least see that through. And it usually works. They usually at least participate in trying it. How does it work with your program? What's the child's involvement?
Yeah, great question, Omkar. Kudos to you and your wife for following the asks of your children when it comes to recipes and food. That's really great to have them involved in that way. So we have focused on families with kids 0 to 5. As you can imagine, it's hard to get children that young really involved in the kitchen. One of the things that's lovely about having parents cook together from their own homes is that the kids are in and out of the kitchen. Though we focus on enrolling families with young kids, of course, many of those families have children of varying ages. There could be extended family visiting or living together. Anyone that wants to be in the kitchen while parents are cooking are welcome to be. We're currently working on adapting Home Plate for families who have adolescents. With that endeavor, we'll then be tailoring some of the lessons and interactions to include kids.
What are the things you're evaluating and measuring? Are the kids eating the food? Are the parents enjoying it? Tell us more about what you've been seeing so far.
Yeah. The broad goal of Home Plate, we've focused on families with young kids and families who are experiencing poverty and all of the stresses that come with poverty in terms of having limited resources, but also potentially physical challenges, right? Depending on where people live, food access might be different or harder than in higher income neighborhoods. There could be time limitation if parents are working multiple jobs that don't have set schedules. So there are some universal challenges that we all face when it comes to eating balanced, nourishing meals, but then certain challenges that will depend on context. And so we have focused on improving food security as well as diet quality. So those are the two outcomes that we look at. In work that we did before the pandemic, we were really encouraged to see that families who were experiencing food insecurity at the start of the intervention kind of seemed to stay in the program for the duration and also have more impactful findings. And so since that time, we have really focused on families who are experiencing food insecurity and or have nutrition risk, right? So we'll look at whether children have overweight or obesity as well. And so we don't necessarily look at BMI because these are very young kids, for one. And so this is not meant to be a weight loss intervention. We're trying to lay a foundation for healthy growth over time, but we look at diet quality as well. And then I should also mention that in the last several years, we have also paired home plate with concrete food resources for families, including produce prescriptions, which are vouchers that can be redeemed for fresh fruits and vegetables at farmers markets, grocery stores, corner stores, all in and around Philadelphia. We've done a couple of studies with home plate and produce prescriptions, and we're seeing some really positive initial findings in terms of when we give families all of the tools that we are offering in the toolkit would be home plate and the vouchers for fresh fruits and vegetables, we're seeing really good positive signal in terms of improved household food security, and then some impact on diet quality, as one would expect for an intervention of a relatively short duration. It's not necessarily completely changing people's dietary patterns, but moving things in a bit of a healthier direction. So we're really encouraged there.
That's great. Zooming out a little bit, there's medically tailored grocery deliveries and meal programs. There's obviously great work that happens with WIC and other programs that really help with food insecurity. What are the tactics that have the most staying power? Combining your kind of healthy plate initiative with other things you're seeing in the community.
So I think that there is unfortunately not one silver bullet solution because this is a very complicated problem. I think that if people do not have enough resources to procure food, then they will not have food to eat, right? That's just a simple concept, but not an easy problem to solve. And that is where programs like WIC and SNAP are really crucial in terms of providing families with material resources for food. You can think of the converse, though, that 90% of Americans do not meet what is recommended in terms of eating a healthy diet. And so, even when people have enough material resources for food, that isn't the only thing that's required to be able to eat healthy. That's where looking at the overall food environment is really important. And we've been talking about empowering families to act on their existing skills and their existing motivation around eating nourishing and balanced meals. But the elephant in the room is that we are all flooded with many options of foods to eat that are not good for us at all. So ultra processed foods and sweetened beverages. Addressing that environment is really critical. And I think the other piece of things is really supporting families with programs like Home Plate. SNAP Ed is a federally funded program that aimed to get at some of the parts of SNAP Ed we're getting at the same goals of supporting families with strategies to put together healthy meals on a limited budget. And then I think the other piece is also thinking about where children spend time. Childcare settings, school settings, those food environments are also really critical in supporting kids with eating healthy diets.
There are programs designed to feed kids at school. So, how can we leverage that to optimize what kids are eating at least half of the time, right? Half of their calories. Because when they go home, perhaps there's a lot of inequity, but at least in school, there could be some opportunity there.
Absolutely. When we look at kind of policy, right, and food systems, changing policy can take a long time, especially at the state and federal level. But local advocacy and policy change can happen more quickly and from more grassroots efforts, and particularly school food environments. That's a place where parents of children at a particular school, pediatricians in a community, that's a place where local advocacy can actually make a huge difference to try to set schools up to have fresh whole foods. So local food procurement can make a big difference in how foods taste, as well as scratch cooking in many schools is not how food gets to the school, right? The food gets there and it's ready to go. Kids, particularly, they eat food that tastes good. And so it's our responsibility as adults to figure out how to make fruits, vegetables, whole grains, all the things we know are really good for us, to put that together in a way that is appealing for kids, and then they will eat it. You're absolutely right. There's a really significant window of opportunity there from an advocacy and policy perspective.
But as you pointed out, the first 1,000 days are critical, right? If we can get kids, their taste buds and their taste preferences really maximized in those first 1,000 days, I think that sets them up well for the school years. If they're eating chips, salty, processed food in those first 1,000 days, it makes it harder to create healthier habits later on. Thank you so much for joining us today. It's been great hearing all the work that you're doing.
Thank you so much for having me. It was a pleasure talking with you.
All right, thank you for joining us for your dose of optimism. Make sure to check out our show notes to get more information about our guests and the work they're doing. Visit our podcast page on the KidsX website to join our podcast community and to learn more about pediatric innovation. Thank you to our sponsors and to our presenting partner, KidsX. Please subscribe wherever you get your podcasts, and remember, it takes a village to make sure our kids grow into healthy adults. So volunteer at your local library, help out at the community center, and thank your crossing guard. And if you're so inspired, donate to your local children's hospital. All right, see you next time.